We're just going to give everybody a few more minutes to join us, and then we'll get started. Okay, we're going to get started. I'd like to thank everybody for coming today. And I'm going to introduce our speaker, Dr. Chris Kuenze, who's the assistant professor and the director of the Sports Medicine Research Lab at Michigan State University. Dr. Kuenze is going to provide a summary of current evidence related to limitations of physical activity following ACL injury, as well as an overview of objective and patient-reported barriers to healthy and safe return to physical activity. He's going to give about a 45-minute presentation, and there'll be time for questions at the end. If you do have a question, you can write it in the Q&A box, and he will be able to answer the questions at the end of the talk.
Okay, thanks, Janet. I'm excited to be here. Thanks for giving up part of your lunch hour to listen to me talk about a topic that I'm increasingly interested in over the last few months. And so before we get started, I just wanted to thank some people that have helped out with this area of research. Dave Bell from the University of Wisconsin has helped and been a great collaborator in collecting much of the data that'll be presented today. Karen Pfeiffer has been our physical activity expert here at Michigan State University that's helped throughout the process. Adam Kelly is currently my doctoral student and has taken the brunt of the data collection load, so I have to thank him. And then Joe Hart has also helped throughout the development process of these projects. So the goals of this webinar, I'm hoping by the end of the webinar that people who have attended will be able to describe the principles and methodology associated with evidence-based physical activity assessment. The second goal is that you'll be able to describe the impact of ACL injury on a broad complement of physical activity characteristics that are measured using a variety of techniques. And the third is that we'll be able to discuss the effect of patient-reported and objective outcome measures on physical activity. And I can be honest up front in saying that point 3 is the one where it is the current kind of emerging area of research. So the amount of information we've got to share today is a little bit limited, but I did my best to try to put together as much as I could. And so before we start talking about musculoskeletal injury or ACL injury specifically, you know, it seems to be relatively important that we kind of understand why this is an important topic for us to discuss. I think we hear enough scary stuff on the nightly news about all the diseases that are killing all of us on a daily or weekly basis, but you know, most of these scary conditions that tend to develop later in life can be traced back to some bad behavioral decisions as well as genetics and a number of other factors earlier in life. One thing that we know is directly related, or in most cases causal, of this disease burden is physical inactivity. So not completing the recommended amount of physical activity at a moderate or vigorous level on a daily or weekly basis. And so from that, you know, we can sort of look at some statistics and say that, you know, a large portion for a single disease or behavior to explain, you know, between 6 and 10% of the disease burden associated with some of the most common killers in the United States, that's something that we need to take notice of. And the fact that it's responsible for 9% of premature mortality is another wake-up call that we need to consider. But for the, you know, the economists in the room, associated medical costs with these conditions, as well as just inactivity behaviors alone, as of 2012, were in excess of $700 billion a year. And so I'm guessing that those costs have expanded over time. And so, you know, that makes up quite a large portion of our annual federal and private domestic product. And so what does it mean to be active? This is a bit of a moving target, but our best current position statement from the ACSM gives us a few guidelines that we can use to better understand what we're discussing. And so, you know, they've kind of outlined this idea that if we're looking at moderate intensity activity, and in a few slides I'll get to some examples of what that might mean, what we're really looking for here is something that's about 30 minutes a day, 5 times a week, for a total of 150 minutes per week. Obviously, there's some flexibility there. If you have a long workout one day, you can go a little shorter on the other day, but the 5 days a week recommendation is a standalone recommendation. So the 150 minutes is great, but it's also the regularity of activity that's important. And then from a vigorous perspective, we can reduce the number of days and the amount of time because the overall caloric and metabolic expenditures associated with the activity are somewhat greater. And so in this case, we're looking for a minimum of 20 minutes a day, 3 days a week, but I know this math doesn't add up, but the recommendation is that if you're just sticking to vigorous activity, that it's somewhere in the vicinity of 75 minutes per week total. And so the bottom line is when we look at the metabolic equivalents, what we're really looking for is 500 to 1,000. I know that's a broad spectrum. The most current recommendations that are not from the ACSM are closer to 1,000 or even a little above. Met minutes per week. So for all of you who are, you know, experts in exercise physiology and have have taken many courses, that's a pretty clear idea. But for those of us who maybe had to go look it up in the textbook, it really discusses the caloric expenditure and metabolic cost of activity over the course of the week. And so it's estimated that this volume and intensity of moderate or vigorous activity should enable you to achieve that level of expenditure. And so it's great to know what physical activity is, but we need to know how to assess physical activity. And so the most common approach to assessment is what's known as the FIT principle, and that breaks down into the frequency of activity, the intensity of that activity, how long you do the activity, so time, and then also the type of activity. So are you playing basketball or going for a walk or doing any other physical activity that you can think of? And so when you're able to categorize or able to measure or able to describe activities across this spectrum, then you've done an adequate job at actually understanding what type and what are the characteristics of the physical activity that a participant or patient that you're dealing with is currently participating in. I think in looking at this, if we all just kind of think in our heads about what some of our common physical activity assessment types might be that we've used either in research or in the clinic, I think we can automatically kind of think about some limitations that some of those measurement tools may have. And so I'm going to discuss that in a few minutes, but I think that's important to be self-aware of kind of what we're doing in orthopedics versus or musculoskeletal injury versus what folks who kind of specialize in the area of physical activity assessment may think is more appropriate. And so when we're talking about these components, frequency is usually the easiest one to assess. I've seen this just from personal experience, but also when you talk to experts in the field, frequency is pretty easy to get your arms around. In musculoskeletal injury research, we've seen, the use of the MARC scale is relatively consistent across the board. Lots of people use it, and they like it because it's nice and easy. And the nice part about the MARCs is that you get a great idea of the frequency of activity, and you'll also get some information about the type of activity as well, which is helpful. But something as easy as a physical activity log, even if reporting is somewhat even if there's somewhat over-reporting from the individual who's reporting their activity, or they're not 100% honest about what types or the duration of activity, at least you'll know on which days they participated in activity, and so that can give us some information about the frequency of which they're participating in activity. And generally in the literature, frequency is going to be reported as either hours per day, hours per week, or days per week. That seems to be the most common way that we would be able to assess that. Length of activity is what's most commonly misreported in the literature, or at least from patients and from research subjects that I've dealt with over time. And so, this is about how long did you actually participate in physical activity. And so I have some little cousins that if you asked them how long they were at school, they would probably tell you they were there for 25 hours, even though they are only in half-day kindergarten. And so, I think of it in the same way when we're dealing with participants who are recovering from injuries. It may have felt like they did 4 hours of physical activity, but it's likely that it was 30 or 45 minutes. And so sometimes with self-report, the length or time of activity is somewhat difficult to recall retrospectively. And so it's much easier to be able to look at the length of activity using an instrumented device that gives you an objective measure of how long the participant was active. And that's kind of where we started to see the rise of the pedometer and accelerometers within this area of research. All right. Intensity, there's some really good definitions regarding intensity. And so moderate intensity is somewhere between 3 and 6 METs, and that tends to be like brisk walking, gardening, dancing. There were some other strange recommendations in this World Health Organization report. Vigorous intensity is above 6 METs, and that tends to be running, cycling, aerobics. I think on a lot of our questionnaires, these are the activities that have you, did you break a sweat? Did you have an accelerated heart rate? Things like that kind of fall more into the vigorous activity side of things. But again, it's difficult if you've got a patient who is not in good cardiovascular shape or in good physical condition. a lot of activities that would really fall in the moderate intensity activity range may feel like they're vigorous. So to ask for self-report here can sometimes be a bit difficult. And then the last one is types of physical activity. So this is an area where we actually have a questionnaire that does a pretty good job of doing that. So the Tegner Activity Scale does a nice job of being able to at least categorize a type of physical activity. We also see that, you know, level 1 versus level 2 and level 3 sports, when we're just talking about cutting and pivoting versus, you know, non-cutting and pivoting sports, tends to try to do this as well. Granted, the categories are a little bit more broad. And then you can see those WHO classifications has attempted to put a MET value associated with some common activities so that you can make a little bit better comparison to recommendations that are currently out there. And so, you know, while this is an imperfect science, unless you're going to put someone in a caloric chamber or something like that to be able to actually understand what the metabolic output is, I think we've got some reasonable guidelines to be able to compare people's self-reported activity. And so, you know, when we look at life after ACL reconstruction, the goal is that patients go on to have or not have ACL reconstruction, depending on what your patient population is and what their decision-making process is. But the goal is that they have a return to activity in the short term, and then they progress out to a return to normal physical activity that stays with them over a long period of time, and they move into healthy old age, you know, free of all those comorbidities and mortality risks that we presented about earlier. And really the goal here is that we're promoting physical activity across the lifespan. It doesn't always have to be participation in Division I sports, but maybe they're just you know, staying very active and meeting recommendations over time. You know, and so what we're really concerned about here is that after musculoskeletal injury, there is some data, not necessarily in ACL reconstructed individuals, but more broadly in just lower extremity or just musculoskeletal injury, that has looked at participation in physical activity after an injury or surgery and recuperation. And, you know, ideally with our clinician hat on, our goal is that the person will, you know, kind of spring right back to the level that we would expect them to be at over time. But, you know, more realistically, when we look at the general patients we're dealing with on a day-to-day basis, you know, the Division I athlete may not perfectly fit this. They're sort of pressured due to environmental and societal pressures to get back to sport. But if you think about your weekend warrior or your recreational athlete or, you know, the guys on campus who play ultimate frisbee or whoever else it might be, you know, the likelihood that they're going to go directly back to the same level of physical activity is probably unlikely. And so we're much more likely to see something like this blue line in the short term that's, you know, slightly reduced or altered physical activity level. And the concern there is that if you've got something that puts someone early in their lifespan on the course to decrease physical activity, as time goes on, as we move through generations and through the lifespan, there's a natural attrition from vigorous physical activity and then a second attrition from moderate to vigorous physical activity over the lifespan that's just expected due to, you know, a number of issues related to other musculoskeletal injuries, other health concerns, degenerative disease, lack of access to physical activity opportunities, any number of factors. And so if we've got a triggering event earlier in the lifespan that causes a reduction in physical activity, you know, the concern is that that's going to become the new pattern over the lifespan. And so we see a decrease, and with that increased risk of morbidity and mortality as time goes on. And so in sports medicine, when we're thinking about assessing physical activity, we really primarily are thinking about three different things. Return to sport, that's the one that we probably see the most information published on a yearly basis. There's a number of reasons for that. One, as a sports medicine community, it's a primary interest for us, right? We have patients who are injured, they want to get back to doing physical activity or sport, and so our goal is to treat them and rehabilitate them to a point where that's actually a possibility. And so, you know, being able to track that outcome is important. It's a bit simplistic in some cases, but it's a really important hallmark for the patient and the clinician to understand how the outcome or whether or not the outcome of interest is being attained. The second is patient-reported physical activity. So this is as easy as, you know, are you physically active? Did you do physically active things today? All the way through some complex questionnaires that I'll sort of show some examples of in a few minutes here. And then the last is objective measuring of physical activity. So this is, using actual devices to track people's physical activity over time to see how much physical activity, what type of physical activity, what frequency of activity, and what intensity they're participating in. And so the goal, I think, is to really give us a multidisciplinary approach towards physical activity monitoring. It's not that one is perfect and the others are bad. I think that they need to work together to give you a complex and comprehensive view of what physical activity actually is. And so when we look at return to sport, it's an important variable because it's clinically meaningful. So it's something that we should be monitoring and something that should be measured. There's no doubt that this is important. It lets us know about re-engagement. We had someone who was disengaged from sport or from exercise, and now we know whether or not they've fully re-engaged, whether they've partially re-engaged, or whether they haven't re-engaged at all. The problem is that we don't know how this applies to the non-competitive athletes. So the general college student or faculty member or just guy that you see on the street, the goal there is probably not a return to competitive sport. And so how can we modify this question to really fit everybody instead of just competitive athletes? Patient report is outstanding because you get it directly from the source. So you're asking the patient and they're providing you with their perspective on their physical activity behaviors. They tend to be relatively time efficient and they're cost efficient as long as you have a printer in your office. And there's something that's easily tracked over time. You can do this as a serial assessment. So there's lots of great things about patient report. The struggles go back to the fact that most people will over-report their physical activity. That's just the way it is. And depending on the structure of the questionnaire or the outcomes of interest that you get from the questionnaire, it sometimes is difficult to make comparison between patient-reported physical activity and what we know to be the common recommendations currently. So those ACSM guidelines about moderate to vigorous physical activity, in a lot of cases, we're not able to know whether or not someone's meeting guidelines based on patient-reported outcomes. And then the last way is quantitative approach. And so, this is the objective measures enable us to actually track how long and how frequently someone's being active. This is consistent or considered sort of the gold standard currently. The problem is that it's time intensive, it's financially intensive, and the data processing in some cases can take a bit of technical know-how. And so these aren't always the most clinically approachable techniques to be able to assess physical activity, although I think there are some options that are currently available, and we'll talk about those that would fit very easily into a clinical model. So I'd like to start by just talking about a brief overview on return to sport. And based on current evidence, here I cite an article from 2010, but I think there's been a number of articles since then that sort of support the idea that somewhere between 8 and 9 months seems to be the most common time for at least an attempted return to sport. There's a lot of factors that can contribute to this being longer or shorter, but I think as a general estimate, that's a reasonable estimate to put on the table. We know that by 1 year post-ACLR, we would expect about a third of participants to be back to full competition among elite or high-level competitive athletes. The interesting part here is that we've got 33% of patients who may not have even made an attempt by a year. As a competitive athlete, this seems like a lot of lost time, but I think what we're seeing from the literature that's been coming out over the last year and a half or so is that these may actually be the smarter of the participants. It seems to have some significant impact on reducing re-injury and contralateral injury risk, and so it's unclear whether or not this is a good thing or a bad thing. And we'll see by 2 years, there's actually been 2 studies that have been released relatively recently that have shown a bit higher number here among very competitive or elite athletes. But among a broader swath of athletes, it's about 45 to 50% of patients you'd expect to be back to full competition. The more recent studies have shown somewhere upwards of 55 to 65%. And again, there's going to be some variation depending on the environment the patient is in, as well as what type of sport they're participating in, a bunch of things across the board. But again, we go back to this idea of what is the measure for a non-competitive athlete? Is it going back to their previous level of physical activity? Is it starting physical activity? What do we constitute? How do we measure that? And so there's some limitations with this measure that should be considered if it's being applied into a non-athletic environment. When we look at return to sport, though, we know that improving patient-reported outcomes, so knee-related function especially, seems to have a positive outcome on success, or a positive influence on successful return to sport. So this isn't just attempting to go back to sport. This is returning to sport and actually being able to maintain a level of competition or a level of participation. And so, you know, increasing KOOS score or increasing IKDC score that kind of matches that time to return, kind of maximizing those patient-reported outcomes seems to have a positive outcome on, or a positive influence on successful return to play. Also, it seems like if you're able to improve patients' conditions to the point where they've got a improved knee-related function or a high level of knee-related function prior to surgery, they've got a little better chance of a successful return to sport earlier on. We also know that there's some psychosocial characteristics or factors that may either aid or cause issue with return to sport. So increased efficacy and increased strength and commitment to athletic goals seems to have a positive impact on successful return to sport. There's a small typo here, so better quality of life ratings and decreased fear of injury also seem to have a positive impact. And then increased motivation for full and rapid return to sport. This is from a qualitative study that was done, also seems to have some predictive value, or at least some influence over whether or not someone is going to make a successful return. And so, you know, as a clinician, we're always concerned about, you know, what about functional outcomes or functional measures, things I can influence or things that I can improve in the clinical environment. And so it seems like having increased isokinetic strength, both in the involved limb as well as good symmetry values, has a positive impact on successful return to play. And then decreased asymmetry in hop tasks prior to return. And you can see here, thanks to Adam Kelly, who made these wonderful GIFs, you know, these hop tasks seem to be relatively common and well reported on. And so, you know, symmetry over 85% on these tasks does seem to have some positive influence on successful return to play. And so when we look at barriers, though, there are some notable barriers that need to be discussed. One is that some non-modifiable factors have significant impact on successful return to play. So females, and this is pretty consistent across a number of studies. There's others above and beyond just the Ardern studies that have shown that in general, females are less likely to fully return to play. So they may return to the same sport, but at a different level. They may opt out of the sport of interest into something that's less likely to, in their mind, cause injury. But in general, females are less likely to return, and then older athletes are also less likely to return. And so, as you'll see later, our young, healthy college athletes are somewhat likely to bounce back a little bit better or a little faster to have a successful return. Elite athletes are more likely to return than recreational or sort of sub-elite athletes. The motivation factors and I think the environmental factors are likely a big contributing factor to that. And then it does seem like those with revision or contralateral injury are less likely to return to the same sport or same level of sport. And that's just likely due to natural attrition as well as potential complication or psychosocial factors associated with the second injury. And then more recently, there's also been a study that's looked at rehab compliance over the 6-month period before attempted return to sport. And I think obvious to all of us, but you know, it's nice to have some data to back up the idea, is that those who are rehab compliant over a period of time are more likely to have an accelerated return to sport and to have a successful return to sport. So there's a number of barriers here, some modifiable and some non-modifiable, but it's good to know sort of what you might be able to do as a clinician in order to help facilitate as successful a return as possible. And so limitations to return to sport is that it really only gets to the type of activity. It doesn't, and it may in some ways be able to assess intensity, but it's not a great all-encompassing assessment approach in order to really be consistent with the fit principle that we talked about earlier. The second part is that it, in most cases, is specific to athletes who are competitive athletes, and so it's a little bit difficult to apply return to sport in some cases to our weekend warriors, our inactive individuals, or patients who are just opting to switch into a different activity based on injury risk or fear of re-injury moving forward. And then the last one is that the variable structure is different. Return to sport is great. It's a primary clinical outcome, but it doesn't allow us to compare to any type of physical activity-based recommendations. So we have no idea how many minutes per week or what intensity per week or how many METs per week an individual is actually participating in once they've returned to sport. So I'd like to kind of transition from return to sport. Return to sport's an important portion of our physical activity assessment, but it's really nice to be able to also have some backup with a more comprehensive patient report approach to physical activity measurement or monitoring. And so when we look at physical activity assessment here, using patient-reported outcomes, we've got a number of measures, and I'm going to talk specifically about a few of those in a few minutes here, but kind of broadly, if we take an overview, the evidence here is a little inconsistent depending on which measurement technique we're using and which tool we're using. It seems like the Marks Activity Scale, which we'll talk more about in a second, shows some decreases in physical activity at 2 and 6 years post-ACLR. Some issue here is that it's a reduction from pre-surgical level, and it's not compared to other contemporaries or other matched controls that are at the same phase in life or going through the same life experiences. So, and we'll talk about why that's important in a few. Tegner scale seems to be decreased 2 and 23 years, well, in a range of times from 2 to 23 years after ACL reconstruction. In some ways, that's consistent with what we've seen with return to sport in the fact that, at 2 years, somewhere between 45 and 65% of participants are going to be back to their full participation. And so we would anticipate that Tegner score would also decline over that period of time, seeing as that's what it's primarily assessing. And then we're going to talk more in depth about the International Physical Activity Questionnaire in a few minutes. There are some areas of the IPAC which may be impacted by ACL reconstruction. To be honest, I don't think we have enough data currently to make a really good, strong case for which of those components would be impacted, but I'll present some kind of original data that discusses this quite a bit. The nice part about the IPAC is that it conforms to the FIT principle, and it also allows direct comparison to guidelines for physical activity. So it's got some advantages despite the fact that we don't quite have evidence to support a decrease in those outcome measures among those with ACL injury. And so I just want to take this opportunity to I'm going to talk about some original data that Dave Bell and I have collected over the last 8 months or so. And so I just wanted to give you some information about our patient population. And so I figured I would do it at the top so I didn't have to keep going back to it. And so we matched 33 ACL reconstructed and 33 healthy control individuals on a number of factors, including sex, age, BMI, and Tegner score. These are all factors that have potential impact on physical activity levels and physical activity behaviors. And so we did our best to come up with a pretty tight group. And I think from our demographic information here, you can see that we were successful in that matching. You can also see that this is a cross-sectional study. So we had patients that were 27 or so months out from ACL reconstruction, but they ranged anywhere from 6 months all the way out to 5 years after ACL reconstruction. And we did that for a number of reasons. We wanted to look at the effect of time since surgery on some of the measures that we were going to record. But I have to be honest up front and say that longitudinal data is going to be key for us to really get our arms around this problem or potential problem, I shouldn't say problem, potential problem in the near future. And so when we look at the Tegner score or the Tegner activity scale, really what we're doing is looking at categorizing level of peak activity over a recent period of time and trying to compare that through retrospective recall to activity level before the initial injury. And so when we do this, we pretty much see that participants didn't vary on pre-injury level of physical activity between the ACLRs and those healthy matched controls. And we also didn't see any difference between those with ACLR and healthy individuals after their injury when we were measuring them. And so we controlled for time since surgery and for sex and for a number of other factors, and it didn't seem to make an impact really on the findings here. It seems as though those with an ACLR and those that are healthy, granted we tried to match based on this, but with limited success, just don't seem to really vary very much based on this questionnaire. We also looked at the MARC scale, so we took individuals who had an ACL, the same group of people, and had them fill out this questionnaire, which gives us some more information, right? It gives us some information about frequency and then also about type of activity. And so when we look at these scores, we're really not seeing any difference between the ACLR and the healthy group yet again. And what we are seeing from the MARC score is that both groups are relatively physically active, a score of somewhere between 10 and 12 for both groups. That's a pretty strong score. The maximum score on the MARCs is a 16. And to be able to categorize in between that 10 and 12, that's physically active. So, for this group, that's a good sign that they're maintaining some level of physical activity. When we look at the International Physical Activity Questionnaire, this is more the gold standard of self-report, and it enables us to look into all of those concepts related to the FIT principle. And the main outcomes that we get is the participant consistent with the ACSM guidelines? How many MET minutes or MET hours per week are they participating in? And then how much activity at these specific levels are they participating in? And so the nice part is we get a comprehensive view of physical activity. And so when we look at this, let me orient you to the graph here. The red boxes indicate what a physically inactive person, the range in which they would fall, and the red or the green and blue bars are responsible for or represent the ACLR and healthy individuals. What we can see is that there's no differences between the groups on MET minutes, which is sort of what the ACSM guidelines are based off of, or just minutes of physical activity per week. And in both cases, both groups are very active, right? This is from a self-report perspective, these groups seem to be highly active, engaged in physical activity, young, healthy college individuals. And so, that was sort of an interesting and also sort of exciting finding that patients seem to be doing relatively well. When we looked at this data in comparison to some things we might be interested in, so we're looking at minutes per week of physical activity on the y-axis, and on the x-axis here we see IKDC score and time since surgery. We saw a few different things. One is that there don't seem to be strong correlations between knee-related function in PA or time since surgery in PA. And we also see that there are some crazy outliers. We see some patients who report upwards of 600 minutes per week of physical activity, which is physically possible, but not really physically possible. It's not sort of outside the range that anyone should be able to report. And I left the outliers in. I have the analysis without them, but I left them in to show that you're going to have patients who don't know how active they are, okay? And so part of the self-report issue is counseling the patient to try to get them to respond truthfully and realistically when it comes to these questionnaires. As you can see for us, despite the fact that we tried to do that, we still had some participants who were a little bit out there when it came to how much activity that they were reporting. And so, as you can see from some of this data, there are some limitations in patient report. The content and construct validity of a lot of our surveys has not been established, which is problematic, especially when we're talking about comparison to actual physical activity standards and not SF-36 score or something like IKDC score. That's problematic. The IPAC has the best supporting evidence, but is also difficult to administer and to score, so that can lead to some issues. Over-reporting is extremely common in patient-reported physical activity measures, and so the MARCs data seems to be relatively consistent across studies at this point, so that's a good sign. The IPAC hasn't been widely utilized in ACL-injured populations, and I'm looking forward to seeing more studies that are quantifying this variable so that we can start to see what should be expected. But when the IPAC and objective physical activity measures have been compared, there are varying levels of agreement between those measures. And then the last part is that some questionnaires ask for some pretty off-the-wall recall times. So some ask for what you did in the last week, some are about the last month, and some go as far as a year into the past. I don't remember what I had for lunch, and I did it right before we started this webinar, and so it is difficult for patients to go back in time and try to come up with an accurate assessment. And so I just want to move on to objective measures for about 5 to 7 minutes here. We'll talk through this, and what we're really talking about objective physical activity is either worn devices, things that actually track the level and amount and type of physical activity, things like pedometers. I see everybody in my department has a Fitbit but me these days. It seems like they're becoming more and more common. It's a great way to be able to objectively measure your physical activity on a daily basis. Accelerometers are currently the gold standard in this area or gold standard strong, but currently the most commonly utilized tool in this area for physical activity assessment. And they are very close to conforming to the FIT principle of assessment, so that's helpful. GPS is less commonly utilized in the literature, especially when it comes to day-to-day monitoring instead of just in a single practice or a single bout of exercise. And so the other problem with GPS is it has some challenges in assessing the intensity of activity. It kind of knows that you're moving around and how far you may have moved, but it's a little unsure about what the intensity of that movement was. And so when we talk about these objective measures of physical activity, we can break them down into moderate and vigorous, but really what happens is we combine those into a moderate to vigorous physical activity measure. And so this is anything that's greater than 3 METs. That's a double S right there for no reason. And so, we're going to look back at that guideline of 150 minutes per week of moderate to vigorous physical activity seems to be what's currently recommended in the literature. And so when we looked at that in our patient population of ACL and healthy individuals, despite the fact that all the self-reported variables showed that there were no differences between groups, what we saw is that the ACL reconstructed group saw a significant decrement in moderate to vigorous physical activity when compared to the healthy control group that was matched. And that was a moderate to strong effect between the groups. Now, granted, both groups are physically active, right? We would hope for about 50 minutes of physical activity per day. That's what our goal is. And both groups are exceeding that. But remember, this group is a bunch of 21-year-old college students who have access to all the physical activity infrastructure they would possibly need to maintain a level of physical activity on a daily basis. And so this might be the ideal environment for a patient who's undergone physical activity. It's still 16 minutes less per day. And from a pedometry perspective, when we looked at steps per minute or steps per day, we saw about 2,000 less steps per day, which was also a moderate effect. And so what was interesting here is that currently about 10,000 steps per day is the recommendation. And in the ACLR group, we saw about 2,000 less steps per day as compared to the healthy group, as well as to the recommendation of 10,000 per day. So this was the first time that we'd come up with a really objective measure of physical inactivity in patients with a history of ACL reconstruction. And so the cool thing from a clinical perspective is that when we look at the healthy group and the ACLR group, and we look at moderate to vigorous physical activity as compared to step count, they correlate very strongly. And so the good thing here is that if you have patients that are using a Fitbit or using another pedometer or have an iPhone or another app on a phone that enables them to track steps, you may be able to, at least in a roundabout way, assess their physical activity on a weekly basis when you're treating them, so to get an idea of what that would be. And the best part is that a lot of these devices will actually send emails to an email address of their choice, it could be yours, to enable you to get weekly tracking updates on your patients or athletes to make sure that they're maintaining a healthy level of physical activity. And so when we go back and look at this idea, the MBPA compared to time since surgery, this is sort of just a rough graphic that I drew up as what I had in my head as our hypothesis. When we actually looked at MBPA and we compared it to time since surgery, we really didn't find any relationship about this the comparison. And so more or less, we saw about an equal number of patients who are physically inactive, below that 150-minute per week cutoff in the 36 months and out, or 6 to 36 month kind of bin of participants. And so this was really surprising for us as we started to unpack the data. We definitely anticipated seeing a decline in physical activity over time, and that just didn't seem to be the case. Then we went and looked at MVPA as compared to like knee-related function. And we also tried to compare step count to knee-related function. And again, there seems to be a limited relationship between these factors. In both these graphs, you know, the red boxes are indicating below recommendations on a daily basis for physical activity, and you can see that there's not a lot of relationship between these variables, which is inconsistent with what we saw with a lot of our patient-reported outcomes or patient-reported physical activity, as well as the return to sport information that we've seen published. When we compared our physical activity measures, our patient-reported activity measures in our MVPA, again, we saw very limited relationships between those. So the MARC score does show some relationship with a non-parametric assessment because it's an odd variable to MVPA. And so that may be a helpful tool to just get a rough idea of what a participant is doing. But a lot of the variables that we were able to pull out of the ATOAC did not seem to closely relate in this population. So in the healthy group, it was much stronger. And if you look across the literature, in healthy individuals, objective measures do seem to track well with the ATOAC. But in this case, that's not what we saw. And so barriers to objective assessment are pretty clear. It's expensive. Fitbit can be, you know, over $100. The actigraphs are over $200, and then you have to pay licensing fees on the software to be able to process data. So that's a major barrier. There are some ways around that. So, you know, Apple Health is free. It doesn't do a great job, but it's a good estimate. It's close enough to get some information on patients. Patient compliance is a bit of a nightmare. So in a structured environment like a grade school or a middle school where you can hand out an accelerometer at the beginning of the day and then take it at the end of the day, the compliance for wear time is quite good. For home-based monitoring, where you hand out a monitor and then let someone go home for 7 days and expect them to wear it, it's a little bit of a nightmare. Patients tend not to wear it as often as they should, and I reference myself in real life trying to wear this as a pilot testing subject. I was not as compliant as I should have been, and that carried through in our future data collections. And then there's just a lot of technical know-how, especially with accelerometers. So when you plug in the accelerometer and attempt to export data, there are numbers of cutoff scores and processing techniques that you can utilize. People argue about which ones are appropriate, and so that can be a barrier. Pedometers may be better and more straightforward for clinical use because a lot of that isn't necessary when looking at step count alone. And so when we look at objective physical activity monitoring, you know, we do a really good job with measuring frequency, time, and intensity. Type is a little bit more limited. The accelerometer doesn't spit out that you were playing basketball or playing football. We ask people to keep a diary of what types of activities they were doing throughout the day. There's also some machine learning approaches that are currently being developed that are able to take the accelerometer counts and kind of guesstimate what types of activities were done. But even with objective assessment, we still may need to include a patient-reported outcome in order to confirm all 4 components of physical activity monitoring. And so as we start to kind of clean up a little bit here, you know, what it really boils down to is that physical activity monitoring, based on the strengths and limitations of each of these measures, needs to be a multifactorial approach. We can't just do return to sport or patient report or objective measures. We need to look across the spectrum in order to effectively understand what's actually going on from a physical activity perspective. The next step, and what's even more intimidating, is we also need to start to understand what factors are impacting each of those 3 components of physical activity. So we have some good information that fear of re-injury and kinesiophobia and other psychosocial factors have an impact. Things like weather, access to exercise equipment, and geography. I live in Michigan. It's really cold, and so, you know, we see decreased physical activity during the winter. That has nothing to do with musculoskeletal injury. It's just too cold to go to the gym or to go outside. And so there are factors that we can only really answer the impact of those factors with longitudinal data. And then there's a number of other factors like neuromuscular function, pain, rehab structure, age, sex, socioeconomic status, and I'm sure there's a million more that may impact any one of these 3 factors associated with physical activity. And so, you know, as a next stage for, I think, my research along with Dave Bell and a number of other groups, we need to start effectively understanding, what we need to use as covariates and what factors we need to understand to better describe physical activity and to impact physical activity positively across the lifespan in this patient population. So main take-home points, physical activity is a critical outcome. It's one of the only outcomes that we have in sports medicine that directly predicts morbidity and mortality. And so being able to assess and monitor physical activity of patients over time is going to be essential for us to ensuring a long-term healthy lifestyle. ACLR does seem to negatively impact physical activity depending on the measurement technique that we're using. So we know that there's prolonged return to sport, or in some cases no return to sport. We know that there's reduced moderate to vigorous physical activity as well as step count, and we know that this may be impacted by a number of clinical factors. And then last, we need to take a multimodal approach to physical activity assessment. So we need to line up, even in sports medicine and musculoskeletal injury research, it's time to sort of move towards using the FIT principle and using gold standard approaches to assessing physical activity instead of staying comfortable with the questionnaires that we've been using for a long period of time. No single method can effectively do this in a reliable and valid way. So multimodal assessment is key. Thank you very much. I appreciate your time.
All right, we have some time for questions. If anybody has any questions, they can type them in. Chris, can you talk a little bit on if we were just to, I know you've talked about this multimodal approach, but if we just want to capture some, basic physical activity, do you think the IPAC is the way to go, or it really is we need to come at it from all directions?
I think that I think the IPAC right now is our best alternative. All right. So if we're looking at what's available in the literature, and there is, if you do a PubMed search on IPAC, you can pretty much find any clinical population that you're interested in that has been assessed using the IPAC. We're kind of late to the party on this instrument, and so I think we need a little more data about clinical populations that we're interested in. But I think if I had a choice between using something like the Tegner and the Marks or some of those other questionnaires or the IPAC, I would definitely lean towards using the IPAC. You just get a lot more detailed information about it. So it's not just are you active or aren't you, but what types of activity, how frequently, what's the duration, what's an estimated caloric expenditure. I know our data was a little wonky, and I think we're still working through why that might have been. But yeah, I think that's likely our best approach in the interim until we've developed something specific for orthopedic populations.
Great. Looks like Dustin Gross has a question. It says, do you think ACLR patients simply don't know or realize that their activity level is low? Is it a knowledge issue, or is it their continued poor function / patient-reported outcomes / pain that's limiting them?
Yeah. I mean, just like Dusty always asks good questions, I think it's likely both. But if I had to guess, it's likely the poor function and patient-reported outcomes / pain and all those clinical factors that lead to the initial issue. At the time of release from care, that sort of guide them towards self-selection out. And there's some qualitative data that's out there about return to sport that makes a pretty good case for this, that there's some functional issues that cause the patient to either self-select or self-limit. But then I'm going to guess, and I mean, this is an educated guess. We don't, hopefully we'll have the data soon to be able to better answer this question. But yeah, I think once they are out and they start to do some recreational activity and start to do some sport activity, they probably don't realize, they don't have knowledge or self-awareness as to how much they are doing compared to what they did prior to surgery or prior to injury. And that's where something like a Fitbit, as rudimentary as it is, and as I'm sure there's going to be better technology within the next few years, but it's not a terrible idea on the way out of rehabilitation treatment or out of your care to tell patients that it's a good idea to track what you're doing over a daily or weekly basis to give yourself some idea of whether or not you're being active or not.
Justin says thanks.
I see that. You're welcome.
There's another question here. Are there any studies that show a correlation between the development of chronic diseases following ACL injury?
I wish. So, I mean, we have some studies that have looked at long-term quality of life, 20 to 30 years after ACL reconstruction. And there have been some reports. It's not 100% consistent across the literature, but there have been some good evidence to support the idea that quality of life is worse in the long term as compared to a similar cohort of individuals who haven't had an ACL injury in the past. Now, a lot of that is confounded and in some way complicated by the development of OA and other, concomitant conditions that may occur at the same time. I'm going to guess that there's going to be some data, I'm guessing from things like the MOON cohort and some of the other larger national database projects to help us try to answer that question here in the near term. But yeah, from a standalone study who's done like prospective data collection and really come up with whether or not someone's got greater risk of morbidity, I don't know of a study that does that. I know we've got some smart people in the room who may have seen something that I haven't, but yeah, I haven't seen that study directly.
Do we have any other questions? Okay. Abby, do you want to say anything, or are we good? Do you need to?
No, I think we're good. Thank you, everyone, for attending, and I'll look for an announcement probably in the September, maybe early October newsletter coming out about our next webinar, which will hopefully be Dr. Brian Petter-Simone from UNC Chapel Hill.
So dreamy.
All right, well, thank you all for coming, and thank you, Chris, for speaking today.
Thanks for having me.